let's restart about data and digital twin. We have seen in the previous session what are the technical concepts about the digital twin, and in this session I would like to show you some concrete examples we have in OneOrtho Medical, and I will explain and show you what we are doing. It's like the practical counterpart of the previous session. The plan is simple. First, who we are. I will present OneOrtho Medical and what we are doing. I will present in the second step the preoperative workflow we have, how we turn raw images into patient-specific models, and how the surgeon use it to plan the surgery. Third, the intraoperative side, how we bring this data into the OR, like we have saw before with augmented reality or mixed reality. And in the fourth section, where prediction is taking part and how we can use it to predict outcomes. And finally, a short and honest note, I can say, on what it takes to turn all this into a certified medical device. And as Florian told us, it's not so easy, and I will try to give some points. Let's start by OneOrtho Medical. OneOrtho Medical, it's a small to medium company. We are 38 collaborators in Lyon, in Saint-Genis-Laval, it's just close to Lyon. OneOrtho Medical is founded in Saint-Étienne in 2013. And one of the winners of the France 2030 Global Innovation Competition. We developed digital surgical planning solutions right at the intersection I described in the lecture between medical imaging, AI, and personalized medicine. And we are a business-to-business company. We support medical device manufacturers. And much of what we build is available at a white label basis. We are just developing technical bricks components like OEM, and they will be integrated in medical devices by others. And what matters most is this: we do not only write algorithm, we developed, industrialized, certified medical devices in-house. And these medical devices are softwares mainly, but also physical devices. Concretely, our work sits on few pillars. The first one is a SaaS, software as a service platform, on which a surgeon and their team log on. They submit imaging like a CT, MRI, and so on, and move through the planning workflow, in which we are running AI algorithm quite underneath to automate the workflow. So nothing has to be built or installed inside the hospital, and everything is available everywhere in the world. I will add some points later, but now we are just developing that for Europe and United States, and the world it's much bigger than that. Second, personalized surgery using the patient imaging to design tailor-made devices. We are designing devices based on this digital twin. Third, additional manufacturing. We have some 3D printers in-house to build and to print devices on mostly plastic material. For example, to make surgical guides, we call PSI, I will show you later. And we have some artificial intelligence models and machine learning algorithms running across all this pipeline to automate the digital twin. And we developed this for several fields. Historically, it's for orthopedics, but we are developing for other surgeries like dental surgeries, cardiology, ophthalmology, and so on, because the specificities are close to be the same everywhere, and the method is very easy to generalize. First, second, the preoperative workflow where the twin is born. Everything starts with the data gathering. We receive the patient CTs or MRIs. An AI is automatically launched to segment, detect anatomical landmarks, and reconstruct the digital twin. And the AI help us, as we saw before, to place the implant at the right place in the CT volume. This is the deep learning part we have already talked before. But the automatic step is not the final word, we can say. A dedicated team or surgeon for some applications are correcting and reviewing the segmentations for mostly the legal reasons. And it helps us to understand better what's the errors made by the models and how we can correct and improve them. And we are collecting these feedbacks like an active learning loop to enrich the models, or not the actual models, but the way we train and the way we annotate the data to make them more confident on these edge cases. In fact, I mentioned it before, but the human guarantee the results. An AI is like a tool helping us to gain some time, make it the effort less, and so on. But it's like a tool. It's not something we can base on and just close the eyes and say, okay, we have a twin. We need to verify and review the segmentation and the planification before going to the OR. And this is the workflow we have in 6 steps: input data validation, creating the digital twin, surgeon approval, like making the recipe and the signature, like saying, okay, it's good, we can go further. Manufacturing the guides, PSIs, deliver, sterilize, and acting during surgery. From the technical point of view, the platform is hosted as a SaaS platform in a HDS certified data center in Lyon. HDS is the certification for allowing us to have this data on the web servers. Clients connect over HTTPS to the system through some firewalls and protections. And they are dealing and calling API and applications made with Symfony and Angular. It's a web-based applications made for desktop and mobile. And these applications are running for mutualized or dedicated clients, because I already mentioned that we are B2B business. And on the side, we have more than 10 clients today and 70,000 surgeries running with this kind of software. And for the AI part, we are calling inside the data center some GPUs with workers to distribute the load, and everything is supervised with all around the clock. Once we have validated the digital twin model, we move to the surgical planning. What we can see on the left side, it's the twin with the bone of the knee, and the implants are automatically placed on the knee regarding the shape and all the constraints. For example, a manufacturer says, okay, this implant is needed for this kind of knee because the size should be this one. And we need to choose between a list of implants and adapt them to the right case, the right patient. And I have already mentioned it. The planning is based on the imaging and the clinical assessment. And these plannings, what we have seen also in the course, is helping the surgeon to think about the plan it should execute during the surgery. And for example, sometimes it's not the case here, but we have some bones called osteophytes. It's not native bone, it's like bones growing with the pathology. And we need to detect them, cut them, and place the implant regarding this non-native bone. And for that, the surgeon needs to try different combinations between implants. And it's the goal and the goal of the planification step. And yeah, after that, we print, if needed, some PSI. It's like a plastic models helping surgeon to place the implant by guiding the cutting of the bone. What we can see here, it's the knee, it's the femoral part here. And we place the implant like clipping the PSI on the bone. And it helps the surgeon to cut here on the bottom and top all the facets we need to place the definitive implant. So far, the model is anatomic, what we called before static medical digital twin, but we can enhance this model with time by incorporating data from IMU or vision-based cinematic analysis. For example, for the shoulder arthroplasty, what we want is to restore the motion of the shoulder for better living conditions for the patient. And the outcomes for this surgery is the motion. And what we try to restore and to plan is the motion of the shoulder. For that, we need to measure preoperatively the current motion and simulate with the implant what the motion will restore at the end. And we can compare with the real motion or the motion during the intervention, because we can place IMUs, it's the very tiny sensors on the patient leg during the surgery to adapt the planning real time. Now we can bring this plan into the OR. We can use, as I mentioned before, PSIs. It's just a static pre-made tools, but we can also use mixed reality. Mixed reality, it's like a big field going from virtual reality to augmented reality with all the steps in between. We can imagine we can place some headsets between the eyes of the surgeon in a complete virtual environment, it's virtual reality, or let the surgeon see through the headsets, it's augmented reality or mixed reality. And it's exactly what we are doing with this. And the big advantages with this, it's immediacy, because when we plan for PSI, we need 3 days between manufacturing, sterilization, delivering, and so on. And if the plan is moving during the surgery because the patient condition moves, we need to discard this kind of PSIs and fall back to manual surgery. And with virtuality, you can adapt in real time the surgery and cope with these last minute changes. And yes, it's one of the advantages. And the inconvenience, because there are some inconvenience, it's you need to wear something or to see some augmented reality or information on a screen. And for now, it's not really well managed in the OR and well displayed. And we need to think about more how to display the things than making it. We have one solution we called Surgiverse. It's a mixed reality solution in which we can display all the components of the planification, from the CT videos from a camera or the digital twin to the headset. It's HoloLens, Microsoft HoloLens devices, weared by the surgeon during the surgery, and it can see through everything, but they are not registered with the patient. It's just like helping tools. And the step I mentioned this morning is we can go further by, okay, trying to register this twin on the patient with markers, and it's surgical navigation. We use some spheres, infrared spheres and cameras, stereomonocular cameras, to track references, like we place a marker on a patient, a marker on the tool, and we compute the trajectories, relative position between the tool and the patient reference. And with that, we can register the planning on the patient. For example, we can use bone morphing. We put the tool on the knee, the surface of the knee. We know that this surface is on the planning there, and we just register the two together. It's a very classical rigid registration. We can also act. We can use a cobotic to avoid placing static guides. We can ask a robot to place the cut, or to guide the surgeon to drill or to cut the bone. And also, what we can do, it's guiding the surgery through the view, the real view, captured with a camera. But the big challenges with this navigation with markers, it's the marker should be fixed somewhere, and sometimes it's not possible. Like in mini-invasive surgery, it's impossible, or in the shoulder arthroplasty, it's very difficult because the bones are very small, and if you drill in the bone, you will break the bone. And it's very, very difficult to place some markers. It's the reason why we tend with markerless navigation. This is one of the examples we are working on. It's a navigation for knee arthroplasty. When you have some troubles due to sports, for example, you are maybe cutting the ACL anterior cruciate ligament, and you should go to the OR to repair this kind of troubles. And for that, the surgeon is using an arthroscope. It's a tiny camera inserted by incision in the knee, and it will see this kind of images. You can see here the knee, and it's the femoral part of the knee. You imagine you are looking from this side. This is the knee, and what we try to guide, it's the drilling of tunnels inside the bone to place the graft. And for that, we are using the medical digital twin in blue, registering to the image. We can imagine several solutions, like placing points, using AI, using everything, to register the two and to guide the surgeon to drill at the right place to restore the motion of the knee. What I'm describing is not like a set of demonstrations. Sorry. Several stuff I showed you are in CE mark products or FDA approved products, and they are used today on the DOR. And reaching this status, it's a very, very large part of the work, and I will come to it with some insights I can give you. But the headlines is very simple. The digital twin is like the form, and it's like reaching patient through certified product, but we can go further by this kind of augmentations, and these augmentations are nowadays in the research step. What we can do with also this digital twin is prediction. What we saw this morning is, okay, we can augment this digital twin with a collection of data. One of the example is in dental surgery. What we are doing is like fusing a CT scan. You can see here with the reconstruction of the mandibular bone. Also, IOS, it's an intraoral scan. The dentist is using a camera to recover the real shape of the teeth of the patient. It's the color made mesh here. And we can also use a picture of the patient to reconstruct the face. And the goal is to simulate the outcomes of smile design surgery. And it's one product we are we are developing. And with this, you can imagine everything is AI, like picture to mesh is AI, registration is helped by AI, and so on. So far, we can augment this twin by biomechanics. We are using biomechanics in shoulder arthroplasty to evaluate the motion of the patient in simulation. And we can also predict the outcomes by saying if we place this prosthesis, this implant there, you will restore the motion like that, or you will face with some issues at the end of the surgery or at T plus 1 month, T plus 2 months. And it's the prediction part. And it's today mainly made with machine learning, but we are incorporating, as I mentioned this morning, also geometric constraints inside this processing to make the prediction better regarding not just clinical aspects, but also geometrical placement of the implants and sizes and so on. And the last section is how we turn these beautiful views into a product. And it's very, very a long path to go to the market. And Florian told us before, but we need to gather some data, a lot of data to train models. More the task is complex, more the data we need. And we need to do it carefully, respecting all the regulation in all the regulation for the country. And we also need to validate everything regarding all the certification we should have before commercializing the product, like MDR for CE marking and FDA approval for US. And like I told you this morning, this validation process is part of the design process. We need to integrate validation steps inside the research steps to make it a continuous flow from the beginning to the end. Let me close a bit by looking ahead. Several things are converging at once. Real-time intraoperative data is becoming richer. As you can see this morning, we can integrate images inside twins, but we have now some limitations. And what we can expect in the future, it's, for example, federated learning, because what the main issue we have is like extracting data from hospitals. And we can imagine hospitals will provide us some computational power to train our model on site and not extracting the data. It will help us to go smarter, we can say. And from the biomechanic part, we can think, and it's a real reality, it can help us to gain accuracy in the planification and make it the plan more close to the reality. Because today, when we plan, for example, a knee implant, we know that we have 1 or 2 size gap between the planification and the real implant put on the patient. It's due to a lot of things like the resolution of the imaging, the way we can simulate the implant positioning. Like if we imagine for the hip, we put an implant in the femoral diaphyse. And for that, we need to drill the bone. And regarding this drilling volume, we should adapt the size of the implant. And it's exactly what we are trying with the biomechanic part. It's simulating the surgery before it happens to make it the planification better. And that's it for me. This is I can say, the transition of the OneOrtho activity from the research paper, the beautiful research we can see everywhere in all the teams around the world, to the products. It's like making something validated and working in the OR and certified. And it's a real job for industrialization. Thank you. If you have some question, I will be glad to answer.
Question time.
No question.
It was really clear, in fact.
Perfect.
One question. In English, it's easier for me. So I have a question for both of you. So I teach at the university, and with this AI wave that has arrived, so it's a bit outside of the technical aspect you're saying. So we see the impact of we start to see the impact of AI on teaching, or mostly on learning of the students. So you rely a lot on expert validation. So the students we have now, they will be your experts in maybe 5 or 6 years' time. And we are all worried that we cannot train our students, so that the students are not really learning certain skills. And at the moment, we really don't know how to cope with it. So from your perspective, what do you think are the risks or the opportunities in terms of how these experts, your future experts, will they be experts enough for you? Or maybe you think you will not need the experts so much, or just a few are enough? So I know it's a bit of a silly question, but maybe you can say something about it.
Thank you for the question. It's a very, very deep and philosophical question, I think. And yeah, from my point of view, just my understanding of the problem, it's AI can help us to gain in speed, time, and so on. But there was a counterpart, like it's like niveling everything, like innovation is less. And yeah, it's my point. I think we are, yeah. For me, it's good because we can. I saw in the team, for example, the juniors integrating the team, they are using a lot AI to do coding, to experiments, and so on. It's good because we can go further and go smarter. But the problem is the understanding behind. They don't really understood what they are doing sometimes. And also they are doing the same as their coworker, because AI is just giving things they learn, the model learn, and it's not innovating, I think. And yeah, it's my point. I think AI is good, but sometimes, not always.
Yeah. From my side, I think that it allows to go faster, for sure. Depending on how you use it, it can allow us to learn also faster, because you can ask specific question. If you didn't understand, you don't have always a teacher close to you. So if you trust AI, but then also for the question about the experts. So I don't know if you are talking also about clinical experts, but at least today we. I mean, in my field with the surgeons, experience. maybe more experienced surgeons to be sure that they have all the skills, and because they will, if they don't learn for the surgeons, if they don't learn at school, at least they will learn in practice, and they will learn from their mistakes, and so at the end they will be good. So yeah.
Yes.
I have a question, but more about the AI part itself, because as we know, people tend to be a little bit suspicious about AI. I wanted to know how it is greeted by the surgeons, for example, or the scientific community.
Yeah, there are, I think, 2 points. The surgeon, by definition, has no time. And if someone does the job for him, it's better. It's one point, I can say. And the other point, it's okay. When we are presenting some results to the surgeon, it's like the way we show him the results could have a very big impact on this interpretation. For example, if we just show to the surgeon the slices of an MRI or a CT scan with the delimited structures on it, it will be very, very attentive to the controls, where the controls are placed or where the controls are false. But if we show directly the digital twin, it will say, okay, it's good, because the shape is what I expected. And it's the reason why in a lot of system we are developing, we are not just showing the slices, we're just showing directly the twin, because at the end, what we need is like a global view. We don't need, in our cases, millimetric, sub-millimetric precision on the bones. We need, in some parts, precision, but we need a global view of the patient to restore motion. It's one of the answer. And the other part of the answer, we are developing some tools to, for example, evaluate uncertainty. For example, a simple way is to add a head to the segmentation model to infer the uncertainty. And we display this kind of information to the surgeon to say, okay, the model is not very confident. Maybe the result is convincing. If not, you can change it. Or you can interact with the model with a feedback loop to say, okay, here it's not good, I can adapt and I can go further. But for me, it's like a partner, and the model is working with the surgeon and not alone. It just, yeah, my point.
Okay, thank you.
Another question somewhere? No. So thank you again.